Um, my name's Greg Hundley, and we've been sort of chatting about some basics and fundamentals of CMR. Uh, Over on the right side of your screen are the login informations to sort of register. If you're a faculty member, remember we do CME and MOC. So in order to get those, though, and also to register your attendance, make sure you answer the question at the end of the study, because I've been doing annual reviews this year, and folks that don't answer the questions, they don't end up getting credit. So please make sure you do that. And then for the fellows, make sure you also type in and register, because if you're trying to get level 1, 2, or 3 in this CMR field, you need 50 hours of didactic work, and this class counts for that. So the way we check on who's showed up and things like that is to to look through that registration link. And if you don't, you can say, oh, as part of the level 2 and level 3, you have to do a number of cases, and you can have all the cases you want, but if you don't have the 50 hours, you still don't get to move forward. So part of the reason, David at Virginia Tech and myself here, we do this is so that you can attend this course and get those 50 hours of didactic. So please make sure that you're doing that. Okay, so now we're going to switch. Thank you, Shannon. And we don't have Corey this week, so I'm going to be trying to run this keyboard at the same time as doing the talk. All right, so remember last week, let me ask one thing. How do guys, do you know how do I move this out of the way? Like this? Is that good? Yeah. Okay, so last week we talked about these voxels, right? And so something like this, right? And we talked about spatial resolution. And within the within the voxels, we're imaging protons, right? And so a component of this whole thing, remember we had also the little guys like here outside of the magnet, the protons are all spinning in random fashion. We go up inside the magnet, they all line up, right? Then we do the FM radio wave, right? And all of the protons tip their spins, right? And then after that, they go back to their orientation in the magnet, right? And they release energy, and we have antenna that pick that up, and that's what we use to make a picture, okay? And we talked about over here that if in order to do this and have visualization of the images, we need a lot of protons. So if we have a low spatial resolution, we have a high signal, right? That's this. If we have a high spatial resolution, we have a low signal because there are not as many protons present, right? Okay, so who's had a, we talked about this just a second ago, who's had an MRI before, right? So what was your MRI scan of?
Cervical spine.
Okay, so cervical spine. So when you were getting ready for your scan, what did the technologist want you to do during the scan?
Do not move.
Do not move. Exactly. They wanted you not to move, right? Because this whole imaging process is very sensitive to moving around. So you guys are all here for a course about cardiac MR. So what's moving? Heart. Yeah, your heart. So your heart is moving. And then also, what else? Breathing. You're breathing, right? So how in the world do we deal with that? So that's what we're going to talk about today. And there are kind of three pieces to this whole thing. Spatial resolution, signal, but now we're going to talk about something else called temporal resolution. Now, let's see if I can do this right. I'm going to stop sharing this. And I want to share this. All right, so this is an anonymized study. And on the screen, can everybody see these sort of cine movies? Yes. I know in the room we can, but what about on the monitors? Can you guys see that?
Yes.
Okay, good. So on the right, we got an arrow here. Remember, we talked about the short axis image. You've got a movie here of the wall motion of the left ventricle and the right ventricle. So how do we do that? How do we create that cine movie? And let's go back to this guy. So over here on the right side of the screen, I'm going to switch colors now. We're going to make you guys have gone to the movie theater recently, right? Some of the hot movies of the summer. There was the Barbie movie. There was the Oppenheimer movie. Remember, the Oppenheimer movie was filmed with a really high frame rate and spatial resolution. And so what I want you to think about over here, whoops, how'd that happen? Ah. So over here on the right side of the movie, on the right side of the screen, are the frames of the movie. All right. So picture the left ventricle. We're going to have way out here at end diastole, the first frame of the movie. And then we're going to work all the way down in the frames of the movie to end systole, right? Looks something like this. So here's our LV right here. So how are we going to make that movie? How are we going to make those frames? So what we do in MRI, inside the bore of that scanner, we talked about, well, here's our MRI scanner. And inside the bore of that scanner, to create that magnetic field, there's a lot of copper wire. And that's used to create a magnetic field. But in addition, within that magnet, sitting right around these bores, are some other smaller magnets that we kind of turn on and off, and that's what you hear making all that noise, all that kind of stuff, right? So here, what I'm going to draw are some QRS complexes, and these are supposed to be regularly spaced. And the way we go about making the movie is we coordinate the picture taking with the EKG signal, so that with the first QRX complex for this window of time in diastole, this piece of information comes over and populates this row of pixels on the first frame. And then throughout this QRS complex, for this moment in time, this one comes over and populates this piece of information on that frame. And for this next moment in time, you get the picture here. This comes over and populates this row. Okay? Then what happens with the next QRS complex? Well, this moment of time, same as this moment of time over here, this comes over and populates this next line. And then this piece right here, this moment of time, comes over, does the next line. Everybody see how that works? And then this guy right here, over, does this line, right? And remember, when we were doing these last week, we had our total distance, which was our field of view. And then we had our matrix, right? Remember that word? And that was how many lines that we were going to put in to fill up the frame. And that's how it works. Okay, so that sounds wonderful, Dr. Hundley. Oh, that's nice how you explained that at Oppenheimer, and that's really cool. But what did we suggest were some common fields of view? Like, if we're going to estimate this distance from front to back, we were talking about, let's say, fields of view of 40 centimeters, or maybe 36, you know, something like that for the field of view. And then we talked about a matrix, how many lines we were going to put in here to fill up that field of view. And we were talking about something like 128 by 128. Or if we wanted a little higher spatial resolution, 256 by 256. What I mean by 256, you got 256 this way, and then you got 256 right this way, right? So that's wonderful. Let's pick the lower resolution. So if we were going to do 128 by 128, how many heartbeats do we need to make up all of the lines in the cine movie? 128. 128. So if your heart rate is 60 beats per minute, that's going to take 2 minutes. Interesting. All right. Now, the other thing we have to account for, someone also said, is respirations. So how do we account for the respiratory motion?
Hold the breath.
Hold the breath. Okay, very good. So you're going to freeze the respiratory motion during this. So is somebody going to be able to hold their breath for 2 minutes? Meh, that's not going to work. So how do we deal with that? So when you guys are doing these scans now, you hear the machine going, breathe in, breathe out, hold your breath out. That's really hard to hold your breath out, I think. If you're kind of struggling for air, oh yeah, hold your breath out. Try that sometime, even if it's for 8 seconds. A lot of times, what you want to do when you do that breath holding coaching is just get something that's going to be comfortable for the patient. Why do we not say always hold your breath in?
Diaphragm might be in the way.
No, because some people might go, and then on the next one, you know, after you're doing this and you sit in there for 45 minutes, you're like, yeah, right. You know, and you just kind of hold your breath in for different amounts of the, I don't know what you call it, inspiratory cycle, right? Different tidal volume. So more commonly, we do breath out because everybody breathes out about the same amount. But if you coach someone and you have someone that's going to be a little bit anxious, you can do, hold your breath in. But just explain that to them, right? That helps with the picture taking process. But now we got to get back to our other problem. Okay, we've got a relatively low spatial resolution here, right? We've got a 36 centimeter field of view with only 128 lines in there. How are we going to deal with that? So you're going to hear terms like gradient strength. Let's go back to our orange. So when you start to see, you go to the Virginia Techs or you go to the VCUs or you go to anybody you want to pick, they tend to get these scanners that might be a little bit more oomph, not just 2-3 Tesla versus 1.5 Tesla, but a little bit more oomph than what you would get if you were at maybe more of a community hospital in a rural area of one of our state. And so what that allows you to do, if we've got a little bit more oomph in these gradients and being able to switch them quicker, is we can really, really, really shrink the time of these little boxes right here. And the time interval that you're going to hear is called the TR. And so this little box can be shrunk down to a period, gosh, I don't know if Dr. Grizzard's here, but 6 milliseconds. That is a very, very short period of time. Okay? Not a lot happens in 6 milliseconds. And so you can take these TRs and you can group them, something like that. So that on this first frame, instead of one piece of information over this period of time, we're able to get, we've got a lot of different lines here, multiple pieces of information in that period of time. And these are called phase encodes. And so we what's called phase encoding grouping. So with the same overall interval of time, originally, we have an ability to acquire multiple phase encodes. Now, all of a sudden, this line right here coming across, instead of one line of our matrix, one row of pixels, one row of depth voxels, we get multiple ones. Okay? And we fill those pictures up much quicker. Okay? We fill them up much quicker. So we use something called phase encoding grouping. And then something else that's really kind of developed in this field about 30 years ago. You know what? And I'm going to take this QRS window here, bring you down here. And so we've got our multiple lines here. And then the next beat is multiple lines here, the next interval of time. We can actually share information from some of these guys from the first interval of time and the second, and create an intermediate interval called view sharing. And we can populate these frames even quicker. So that's how we take that 128 by 128 matrix, and instead of being 128 heartbeats, we can shrink that down into about 8 heartbeats. And that's why your breath holds are 6 to 8 seconds. Okay? And you can hold your breath during that time, and you've got wonderment. Okay, well, that's great if the heart rate is regular and the heart rate is 60 beats per minute. Right? Now, how do does anybody, maybe we'll try this. Okay, everybody got that? All right. Now, I think it's this one. Here is our original QRS. All right, now we're going to throw some issues at us because in cardiovascular medicine, not everybody has a heart rate of 60 beats per minute. So the first thing we've got to deal with is what happens if the heart rate is faster. Okay, so now we're 120 beats per minute. So let's pick 140. You can have 200, doesn't matter. So this is something that all of the technologists and all of you need to know. What are we going to do to change our strategy with the fast heart rate? Well, in the slow heart rate situation, we had all of this interval of time, right? And we've got this beautiful movie over here that's got lots of pieces of information acquired, right? With the first heartbeat, the second heartbeat, etc. In this situation, though, we've got to keep our temporal resolution sufficient so that we can identify end systole over here on the right side of the screen. Okay, we've got to be able to identify the time interval that's end diastole and end systole. Well, if we keep our old strategy and we take these guys and we take this group and this group and this group, you know, similar to what we did up here. We keep these group sizes really big. We won't have the temporal resolution. You can have a choppy image, right? Instead of this smooth, right? You're going to have something that's like you're captured here, and then here, and then here. And you could miss systole. You know, people can see my hands here. But, you know, it's going to be a choppy image. You got here, and then here, and then here's systole. You're back here, you miss it. So the key point, this was called phase encoding grouping. Because we grouped these phase encodes, all those little lines, so that we could get through over here on the right side of the screen, we could get through collecting all the frames in the 8 seconds. But now we've got a faster heart rate. And we've got to have a higher temporal resolution. Okay, we've got to have little teeny groups. Right? Instead of here, where we're grouping this many phase encodes together, here, we're only going to group a few together. All right? So when we come over to this area, we're only picking 3 at a time. Whereas here, we might have been grouping 6, 8, 9 at a time. And so your breath hold, because we've only got 3 at a time, that's going to go up from 6 to 8 seconds to like 20 seconds. Well, that's not going to work because who has a heart rate of 120 beats per minute? People with heart failure, LV dysfunction, they're going to be able to hold their breath less. But your collection intervals are twice as fast because the heart rate's gone up. So what happens what the technologists have to do, remember, every time we set a scanner, every time we go and do a scan, we are programming what we're going to do, right? It's not like turn on the echo machine, turn on the fluoro in the cath lab. We're running a computer algorithm. And so the thing that you have to understand is that as the heart rate increases, we decrease the phase encoding grouping. But we're okay because the heart rate, the number of times we're going to collect, is sped up. Instead of one piece of information every second, we've got multiple pieces of information coming twice as fast. Does everybody get that? That's key. So fast heart rates, less phase encoding grouping. But we're okay to fit it in a breath hold because the heart rate's twice as fast. Everybody got that? How will you know that your temporal resolution is inadequate? The image is going to appear smudged. Okay? If it's a blurry, smudged image, you got one of a couple things happening. Either, we'll talk about this in a minute, either A, we're not finding these QRS complexes from which to initiate the trigger, or we've got an issue with this heart rate thing. Okay? Next. Any questions? All right. Okay, so this is tachycardia. This is normal sinus rhythm. What have I got here? AFib, atrial fibrillation. So one of the things we've been talking about is that we are assuming to capture the heart motion with all this gradient stuff and changing them and the TR and all this stuff we've been talking about, is that the RR interval was regular. So that's nice because the heart is going to be at the same spot over time with each heartbeat. Well, now we got a new problem. We have an irregular heart rate. So do we not do cardiac MRI? What do we do? How are we going to deal with that? So one thing to be thinking about here, we're going to talk about retrospective gating. And we're going to talk about prospective gating. Does anybody know how the scanner, most of the images that we collect today, particularly when the heart rate is regular, it's with retrospective gating. Does anybody know what I'm referring to by that? So let's go back up here. We're getting kind of busy and I don't know how to erase anymore. With our normal sinus rhythm piece. So we're back up here. I'm going to change colors. That'll help. So when we are doing, we're going to focus for those that are online on our normal sinus rhythm situation up here, heart rate of 60. So what's actually going on is you'll hear the scanner when it's running it's just going to be kind of a constant hum. You know, this is what it's doing. It's running all those phasing codes just constantly. And those are all supposed to be equal distance apart, just like that. You know, so what you hear is breathe in, breathe out, hold your breath out, and then you'll hear the scanner go. Well, this is what it's doing. You know, it's just running this entire line here. And it knows how many frames it need, you know, your movie is. It knows your temporal resolution. And so it's going to collect enough stuff over time to fill out all this movie stuff right over here on the right side. And then you'll notice when the scanner is running, very key is up here are these trigger signals. And it is looking for something repetitive over time. It could be the QRS complex. It could be the T wave. Sometimes we use pulse gating. We trigger off the pulse. What the computer is doing is it's looking for some consistent trigger so that it can reorganize all of these guys coincident with the trigger that it's been assigned, whether that be the QRS or any of those things. So most of the scans, when you are performing them, are using retrospective gating because the RR interval is regular, right? And that works here too. You know, it's the same thing if it's tachycardia. Okay, it's just grouping these together in smaller intervals than up here when it was doing this, right? Well, now we've got this situation. Now we can have great triggering, right? So we see the QRS complexes, but we got a new problem, right? Right? So when the scanner goes back to reorganize, right? It's like looking, wait a minute, I've got this many of these guys here, and I got this many of these guys here. What do I do? And you get a smudged image. So retrospective gating does not work for AFib. I mean, maybe if the RR interval is pretty regular with AFib, it'll work. But most of the time, it's not going to work. So what do we do? This is where your cardiology knowledge comes in, okay? In the situation of AFib, if we're thinking about systole versus diastole, and you have a different RR interval, which component of the cardiac cycle changes? The systole change as the RR interval changes? Does diastole change as the RR interval changes? Do both change? Which of those three? Something's got to change. Diastole changes. That's exactly right. So diastole is what changes when the ventricle is filling. So what you could do is we've got a really nice, we're at Virginia Tech, VCU, another academic center, or even a clinical center that's got a really nice magnet. We can change these guys really quickly we can gather information very, very quickly, 6 millisecond time intervals. Okay, and what we want to do to get that cine movie over here is we're going to image systole very consistently and only early diastole. And we switch to something called prospective gating. Right? We're going to switch to something called prospective gating. And so the scanner is going to sound very different. It's going to go ma, 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 ma. It's going to make sounds because it's going to look for the QRS, and then it's going to activate the scanning process when it sees what you've identified for it to recognize as the appropriate interval of time. Okay? Now, one thing that's kind of nice about this strategy, whether we're dealing with normal sinus rhythm, tachycardia, or atrial fibrillation, or even an irregular rhythm with PVCs we throw in here, is you get automatic averaging with either of these techniques. You know, in the cath lab, when you're tracing your LV grams and you got a patient with sinus rhythm, you end up tracing 1. If you have a patient with atrial fibrillation, you have to trace, I don't know what Zach and Barbara make you do, but in my days, you had to trace 10 and average them. In the echo lab, if you're going to be trying to calculate volumes and all this, if you notice on the routine echoes, we trace 1 cardiac cycle. If you've got somebody with AFib, we do multiple, should be 5. Well, here, with all of this technology, you get automatic averaging, right? Because remember how these pictures are created, pieces of information that came over in this period of time, in this period of time, in this period of time, they were all being used to fill parts of these images, right, over time. So you get kind of an automatic averaging. It's a really nice averaging technique, but you've got to understand that when you've got an irregular rhythm, that you're going to switch to prospective gating down here, because systole, that time interval, is not going to change as this RR interval goes, and that's what you're going to be taking a look at. Okay? So we've talked about normal sinus rhythm. We've talked about tachycardia. We've talked about irregular rhythms. All of this is now to balance, in addition to earlier, we've been talking about spatial resolution and signal. The new factor that we've got to add in is temporal resolution. So it's constantly a balance between when you're acquiring studies. If we take the temporal resolution and make that really, really high, are we going to be able, in the window of time, we take it down to 2 milliseconds or 3 milliseconds, you're not going to be able to sample your voxel with enough time interval to capture the activity of all those protons. Okay? So what Shelley and team are constantly doing, and you guys, when you're looking at the images, is you're balancing the temporal resolution, the spatial resolution, and the amount of signal to get the images. And we do a lot of that for you because folks that have been doing this for a long time, have come up with some pretty good standards to collect these images so that you get pictures like that. But you're going to run into the images with this technology are relatively easy to interpret, but it's when you run into a problem that you've got to make an adjustment. And the folks, you guys on this call today, on the Zoom call, and then also in the audience, now you know these basic fundamentals, and you're making just simple adjustments so that you can get the image capture that you need, okay? Now, that all sounds great. Let's see if I can get the eraser back.
Yes. Perhaps.
Yeah.
On the top right, there's clear. If you want to complete like.
Okay, I hate to lose everything. Let's see what this one is. All right. Now, all of that's great. Until we get to another problem. Who knows what rhythm this is? But the new problem is, and here's AFib. What if you cannot find the trigger? Right? The way that algorithm works up here, when the scanner is looking for the trigger, it could look for the amplitude of this RR or this R wave. It could look for the slope of the upstroke. It could look for the frequency of it. There are a lot of ways that these gating algorithms work, but there's times when either because the QRS signal, we just don't appreciate it very well, or we have a lot of PVCs, or sometimes we get a QRS like this, and then we get another one like this, and there's just massive confusion. So there's no trigger. The triggering whether we're trying to do prospective or whether we're trying to reorganize and do retrospective, nobody can find what the heck's going on. So what do we do then? Why in the world would I have talked about all this temporal, spatial, and signal stuff? Well, the last form of imaging that you can switch to is called real-time or snapshot imaging. Now, in snapshot imaging, instead of the retrospective, prospective, very nice spatial resolution, very nice temporal resolution, beautiful signal, you can switch to a technique because you're likely at a site that's doing some high-end stuff. It's got a very nice scanner over here. You can actually try to capture the entire movie in time. So now you're capturing not phase encodes, but this is the whole frame in intervals of time. There are a lot of tricks we use to do that. We don't have a lot of time to describe all those tricks. It has to do with the antennas, how we put images together. But the key that I want you to remember, why wouldn't we do this all the time? Why wouldn't we do the real-time imaging or the snapshot imaging all the time? Well, because of this. These snapshot images, if we're trying to collect all of this, instead of these beautiful acquisitions of lines and all the averaging, we're just going to go blam, 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 blam. Your spatial resolution of these images, how many lines, your matrix, it's going to be low. So in real-time imaging, the spatial resolution is lower. The other thing, look how wide these boxes are. The temporal resolution is low. Right? And because you're collecting the whole box, all of this space, right, at once, within the box, the voxels and the pixels, the signal is low. Okay, so that is a fallback. Now here, we have worked a fair amount. A lot of this comes over from all the work that folks are doing on the research side with Jennifer Jordan and Justin Canada and a whole bunch of people that are interested in getting quick pictures and having some relationships with Siemens and all this kind of stuff. And the scanners and whatnot. And so we have some reasonable sequences, but you want to make sure when you switch to this that you have 40, 50 millisecond temporal resolution, because that gives you enough frames in the movie to appreciate end systole and end diastole, so that you accurately calculate your ventricular volumes. Additionally, you want to have enough signal and spatial resolution so that you can appreciate the endocardial border. Okay? So today, the focus was, there's one more talk here about how we measure blood flow, and we don't have a, maybe I'll do that in about 5 minutes. But let's kind of review. We're going to start with the purple and the pink up here. Last week, we talked about voxels and pixels and fundamentally how we're getting the image that you got up here in pink, right? And we talked about the spatial resolution and the signal to noise. High spatial resolution, less signal in the images, right? Then we started off the conversation today. We asked someone that had had a scan of their neck, what was the first thing that the MR technologist asked to do? Be still, okay? The whole technology is assuming that nothing is moving. Here comes, oh my gosh, you're going to do cardiovascular examinations. Well, the heart is beating. Additionally, we've got to deal with respiratory motion and breathing. So what we identified, we look at this normal sinus rhythm, is that the motion of the heart is rhythmic. We started with a heart rate of 60 beats per minute. And we showed that if you could collect information synchronously over time, in windows of time, repetitively, we could create movies of that wall motion over here. Just like the movie film in Oppenheimer shot at 70 millimeters. Which apparently is pretty impressive if you go to a movie theater. However, not all patients show up with a heart rate of 60 beats per minute. And how we're organizing the collection of those images has got to change when we deal with tachycardias. We organize our image acquisition where we create the pictures with fewer lines of our matrix. However, we're buttressed in that because the heart rate is twice as fast. See in this next row. So the duration of the breath hold does not have to change. And it's all set up for you guys at about 6 to 8 seconds of time that they hold, participants hold their breath. When we go to reorganize the images, most of the time in these two top situations, tachycardia and normal sinus rhythm, we're using something called retrospective gating. You hear the scanner, breathe in, breathe out, hold your breath. All the information is being just collected constantly. And then after the fact, retrospectively, these triggers, the computer goes back and reorganizes all this stuff based on the triggers that it saw. However, now we deal with other irregular rhythms. So we talked about atrial fibrillation. That won't work. Okay? You can't tell Chris, Shelley, Terry, anybody. Use retrospective gating in AFib. I know it works. Wrong. You've got to switch to prospective gating. Right? And when you switch to prospective gating, you are assuming that systole doesn't change in time. That's what we talked about right here. And that's a correct assumption. And the images come out quite nice. There will, however, be points of time where we can't find the triggers. Now, when you can't find the triggers, it's not like, oh, let's go and switch to real time. What you should do if you're a technologist, if you're a fellow, if you're a nurse, if you're whatever, is go in, reposition the leads, try to figure out a way so that you have some type of consistency. It can be anything. It can be the pulse. It can be whatever, so that you can capture images using one of these other methods. But if you can't, then you can switch to real-time imaging. But real-time imaging has some headaches. It has lower spatial resolution, lower temporal resolution, and less signal. The pictures are not going to be as bright. You're going to have examples of that as we go through the year. You have to make sure in cardiovascular medicine that you have this 40 to 50 millisecond temporal resolution so that you can appreciate end systole over here and end diastole. And you've got to have enough spatial resolution so that you can clearly demarcate the endocardial surface. Okay. Any questions? Yes.
So when you talk about a PVC, instead of the regular rhythm, you can still find the triggers. But when you do the average, do you take the PVC out when you do the calculation?
Yeah, what happens there is the information when the PVC occurs, see, it's going to see this is a trigger, and this is a trigger, and this is a trigger, and this is a trigger. It's not going to see that one. So it doesn't include it for you. So you're going to balance that with something like Bigemini. And you just run it once and see what you get. If it's still smudged, then you're probably going to have to switch down here to the real-time strategy. Good question. Anything else? The one thing we didn't get to cover, and this lecture series is supposed to be 3 talks, is how do we measure blood flow and how do we assess myocardial perfusion? And maybe sometime later in the year, we'll talk about that, because that's probably, those 2 things are some of the more sophisticated but best ways to measure blood flow that we have in cardiovascular medicine. And fundamentally, what you do is you're dealing with some of all this. And again, we can talk about it later, but it's a very elegant technique of how we use some of this phase encoding stuff, and we create the velocity maps so that we can measure blood flow. We can talk about that now. Okay, Well, let's end this whole little doodah. Any other questions? Okay, well, it's been a great little 2-session series. These are kind of fundamentals that we all need to know, and then now we'll be working in some examples and things like that. Hope everybody has a good rest of your day.